So I hope I don't have to go into the basic aspects about consent because you're all professionals who would be uh, experienced in taking consent from patients for various types of anesthesia and for various procedures. So I don't think this should be a lecture class on the basis of basics of consent, but I'll just touch through some basics nevertheless, and then discuss about what would constitute or what are the steps of a legally valid consent, what are the ingredients of a legally valid consent, and what would constitute a legally valid consent. Okay. As we all know, the consent comes from one of the basic principles of bioethics, which basically are four. There is a duty not to do harm, or the principle of non-maleficence, or and then comes a duty to do good, or the principle of beneficence, and then thirdly comes the principle of autonomy, patient autonomy, from where actually the concept of consent comes over. So the key words to be focused here is to keep the dignity of the patient intact, understand that the patient has got the freedom to choose what is good for him, and finally it is his choice when he gives consent. So if we look at the literal meaning of this word consent, many of us would have different meanings. Some people would say that it is permission. Some people would say it is assent, or somebody giving, somebody who says he is okay with what you're going to do with him. But the legal meaning of consent is basically, or informed consent, is nothing but an informed choice. It is a choice. So when we say choice, there should be choices. So ultimately, a patient, is a human being who has got a health problem, which he can't solve by himself. That's why he has approached a professional. And if he had all the knowledge and the skill which we had as doctors, then he wouldn't be coming to us. So he's basically taking professional help from people who can find a solution for him when he has a problem whose solution is which the problem for which the solution is not available with him. That's why he's here. But then we should understand that him having a problem or him having not much knowledge about his problem does not take away the right for of that patient to decide what is good for him or what should be done with him. So, being in a position of command or somebody who is less knowledgeable than us or who is less skillful than us or who has a problem and we have a solution, we should never forget the fact that patient autonomy is honored. So, to be, if you want to describe it in one single sentence, this is taken out of a court verdict. So, it just says it's a settled legal principle that every human being of adult years in our country, that's 18 years, every human being of adult years in sound mind has a right to determine what shall be done with his own body. And a surgeon who performs an operation without his consent commits an assault for which he is liable in damages. So assault is a crime. So it will have, and somebody who's asked to pay damages is basically paying for a civil compensation. So you're basically doing, when you're touching somebody or doing something without his consent or without his permission, we are doing a tort in as in case of a civil wrong, which should be you will be asked to pay damages or compensation. But you'll also be doing a crime of assault. But now let us come to the perspective of the anesthesiologist, where it's nobody's case that an anesthesiologist is going to give anesthesia to a patient without him knowing or without him consenting to. So what we are more concerned is not about the nuances or not about the basic fabric of consent as to whether you're giving anesthesia without a person's knowledge or consent, but what would constitute a proper legal consent, and also the use and scope of a properly taken consent. That's what I'll be focusing this talk on. But this is just for 15 minutes, and I know I have to finish this topic within. So we won't be going to the details of everything, but what I hope to do is a transfer of a certain concept, a conceptual transfer. Okay, we all know that there are types of, mainly two types of consent, implied or express. So in the realm of anesthetic practice, we are not talking about implied consent at all. So it has to be expressed, and express consent can be oral or written. Examinations on minor patients as well as therapeutic procedures done on minors as well as majors. We would, meaning any examination which goes beyond an inspection or palpation, in some cases palpation of private parts which intrudes into the privacy of a person should also be expressed. So it is always safe for a doctor to have the presence of a disinterested party while he is taking consent, just to make sure that if the question of consent arises in the future, so somebody disinterested can vouch for the fact that you have taken a proper consent. Many people would think that written consent is more legally valuable or legally valid. Not so. An oral verbal consent is as valid as a written consent, but the written consent has got the advantage of easy proof. It's a permanent form, can be carried to courts of law and can be reproducible. So that is the only advantage. Not that something written has got more value than what has been said. Basically, does not stand much legal scrutiny. So there is another concept called the scope of consent, which basically says that you can only do certain things to which the patient has given permission for you to do. So it's limited to the parameters expressed in the consent form, and you should not be exceeding the scope of what the patient has actually given you permission for. Okay. So let's get into the purpose of informed consent. Like I said, a lot of people think that informed consent is basically about the patient giving a permission for something which you ask the patient for. Like you want to do surgery or you want to give anesthesia, and you are going to tell the patient that that's what you're going to do, and so the patient gives you permission to do so. But like I said earlier, informed consent goes beyond mere permission. It goes to the purpose of taking such a consent is to give the patient sufficient info. I have highlighted these things in different colors for easy readability. To give the patient sufficient information so that the patient has got an opportunity to exercise a knowledgeable and informed decision about the use of a drug or device in the course of treatment. So three key factors are here. One is that the patient should have sufficient information. Why should the patient have sufficient information? So that the patient has got an opportunity to exercise what? A knowledgeable and informed decision. Basically, you're giving him choices, and the patient makes a knowledgeable and informed decision, an informed choice as to what he actually wants to undergo. Okay. So the patient's right of self-decision can effectively be exercised only when the patient possesses enough information to enable him to make an intelligent choice. So if we take a slight detour from the topic of this class, in earlier days, we used to think that good communication skills are something which is desirable in a doctor's repertoire of skills. But now we understand that if a patient is to make an intelligent choice as to what is good for him, he should have full information, and that full information is to be understood by a person who is not a medically trained person. So he is actually depending upon your communication skills to enable him to make an informed choice about what is good for him. So good communication skills are now no longer thought to be a fancy, desirable quality in a doctor, but it is a fundamental aspect of medical practice, and it is now even a patient's right to think that it's among the patient's right to expect that the doctor who speaks to him has got good communication skills. So having bad communication skills is simply bad practice, because you're not enabling the patient to make an informed choice. So with regard to consent, the patient rights would be the right to expect an adequate standard of care from his doctor. Adequate standard of care, which means it meets accepted standards of medical practice. He also expects the doctor to give him full sufficient information. This he gains after he has given all information to him as with regard to his disease. So he would expect it back. He has got a right to know who is going to give anesthesia, who is going to give post-operative care, who will be the decision maker if a problem happens to him. So all these things are patient's rights. You can't keep it away from a patient. He has got a right to know what is wrong with him. He has a right to know what is going to be done. So these are basic patients. I'm not going to the legal terminologies of all this, but as doctors, we should understand that these are the basic patient rights. Okay. So for informed consent to be legally valid, it has got three components. One is, as you've seen on the screen, full disclosure, voluntariness, and competence, and we'll go into each of those. A full disclosure means that a doctor should explain what is wrong with the patient, what are the treatment modalities available, what is going to be done to him, expectation of treatment, and a likelihood of success with the kind of treatment which you're going to suggest to a person. Or are there reasonable alternatives and outcomes? So suppose in anesthesiologist practice, possibly you're going to discuss about general anesthesia, spinal anesthesia, or regional block anesthesia or local anesthesia. And then you may have to explain to the patients about what it means to be under these various types of, what would be the experience. So that's what the patient expects out of you. Okay. And reasonable alternatives. So suppose you're going to choose general anesthesia for this patient, then what could be reasonable alternatives of anesthesia, and what would the patient experience differently in terms of money experience, or even morbidity or complications. Okay. So that's full disclosure. So in olden days, when we used to, there was a school of thought which said that doctors, if they thought that the patient got to know about all this information, it would pose serious psychological threat to him. So doctors thought that it was their privilege to withhold some information from the patient, information with regard to what is wrong with him or what is actually going to be done with him. This is not legally acceptable. This is also called paternalism or grandfathering, taking matters into, and it goes against the basic principle of autonomy. Well, you may have exceptions to disclosure. You may basically not disclose information to the patient as long as if the scenario is that the patient has already told you that he does not want it. So he is probably named a person, somebody who can take a decision on his part. So if you're doing that, it is always ideal, and it is mandatory to have that documented, because basically you're going to do something without the signature of a patient consent. So the other scenario is emergencies, as we shall shortly see. So proof of disclosure, there's a proof that you have told this to the patient. It can be either by documents, which is the most common form which we have now. These are basically paper sheets in which information is written, and all what you have got at the end of that sheet is a signature by the patient or his relative saying that they have read and found out and they have consented to this. A lot of cases have come up where the patients and bystanders have just said that under the stress of the situation, they never read this thing, they just sign. So the fact that, but then we are using consent as a defense when a case comes against a doctor. It's up to the doctor to prove when somebody claims that they did not actually really consent, they did not really understand. It's the burden of proof of proving that the patient and relatives actually did understand the consequences of what they were consenting to. That has to be documented properly, and the burden of proof in such cases may shift to the doctor to prove before a court of law that the patient indeed consented. So eyewitnesses, again, there is a problem with eyewitnesses in the fact that most witnesses in a hospital would be working under a doctor, a nurse, or an attendant, or a hospital staff, and questions of bias may be raised. So the best way nowadays, we have got, almost everybody has got a handheld media recording device. So hospitals should have a video recording or at least audio recordings of the consent taking procedures, especially in cases where you anticipate a legal problem, especially in cases where you anticipate complications and possible litigations in a case in the future. Or when you anticipate, you deal with certain patients and certain people, you would anticipate that this might be trouble. So whichever be the case, it's better that you have an institutional policy regarding all this. But just understand that taking a shortcut in not accurately documenting the procedures will only hamper the interest of the doctor when the question of a proper consent is raised in a court of law later. Okay, that is full disclosure. The other thing is voluntariness. The second aspect of informed consent being valid is that the patient should be voluntarily giving his consent, and it should be free from coercion or unfair persuasions like discount rates, or it could be threat, or it could be the lure of money, or it could be the lure of having to participate in research. Whatever be it, a patient voluntariness will be assessed by a court of law if that is a question which has been raised with regard to the validity of a consent. But as doctors, we should understand that that is enough. You should have enough common sense to understand that a consent is given voluntarily, and it's free from, like I said, audio and video recording, body language of the patient, the demeanor of the patient while giving the consent may influence a court's decisions to finally come to the conclusion whether the consent was voluntary or not. And finally, the patient should be competent. A person, like I said, a person of adult age and a sound mind is a person who can consent as per Indian law. So a subject should be above the age of 18 to give consent to any serious procedures which could harm him or result in death or injury. And this person should have the capacity to weigh reason and make reasonable decisions about the risks and benefits. So that's what the law assumes, that a person will not have that capacity to weigh and reason and to make a rational, reasonable decision if he's below the age of 18. And needless to say, it has got both cognitive and affective domains. In so far as that, a person should have enough knowledge. The cognitive aspect is about knowledge. He should have enough knowledge, then only he can have the capacity to weigh and reason. And of course, it has affective domains in that the patient's decision may be influenced by cultural, social, religious, and other aspects which has to be taken care of. So in India, the consent for a physical examination which does not involve any harm, the minimum age is 12 years, and the consent to suffer harm from an act not intended to cause death, because we don't intend to cause death or give us that by surgery or anesthesia. So when somebody is giving consent to a procedure which has got the potential to result in harm, then that person should at least be above the age of 18. So it's a doctor who should be disclosing. You should be disclosing the information. Nurse or other providers may only supplement. And if there are a team of doctors performing a team, each substitute doctor has got independent obligations, because when something goes wrong, we exactly may not know about what could actually be going on. Is it the surgeon's fault, or is it the anesthesiologist's fault, or is it post-operative care? So basically, the patient should be knowing who all is going to do what all to him and at what all phases of his treatment. So that is where a substitute doctor's independent obligations comes. So we'll discuss the steps of a legally valid consent. Okay, there are 3 or 4 simple steps. Okay. They are: both doctor and patient should make an assessment taking into account the patient's medical history, views, experience, and knowledge. So it should not be just a monologue between the doctor and the patient. It's a teamwork. It's shared responsibility from the patient and doctor, because unless the patient gives you enough information with regards to his views and past experience of having been through surgery, or even phobias with regard to needles, or ICU stay, or the beeps of monitors, may actually be civilized. So people may not like it. So people may get scared of it. So we should have an idea. The communication should be such that the patient should be clear as to what is going to happen to him after a procedure. So unless we make a joint effort at assessing the patients, we may not be able to know actually what the patient really wants. The doctor then identifies the relevant investigations and procedures to benefit the patient and explains the options, like I said earlier, with their respective potential risk, burden, and side effects. But whatever be it, the doctor may recommend a particular option, but we should understand the principle of patient autonomy, and then we should realize that the decision ultimately remains with the patient. What shall be done with him ultimately results with the patient. So when you're giving me a lot of choices, the patient weighs up the potential benefits, risks, and burdens, and any related issues, and makes a decision. He makes an informed choice as to how to proceed. Having said that, the patient may request a treatment that the doctor considers of no overall benefit. The doctor does not have to provide whatever treatment the patient may actually request him, but explain to the patient as to the reasons why the patient's preferred mode of treatment may not be beneficial, but ultimately the bottom line is that the responsibility of seeking consent is that the doctor undertaking the investigation or treatment, not the patient's responsibility to give consent. Basically, consent has to be sought. With regard to legal protection, these are just certain sections of the Indian Penal Code 87, 88, 89, and 92. I'll just rush through it. We are not culpable. We are not to be punished for an act which is not intended and not known to be likely to cause death or grievous, done by the consent of the person. Again, an act which is not intended to cause death, done by consent in good faith, not punishable. Act done in good faith for the benefit of child or insane person, or by the consent of a guardian, not punishable. Act done in good faith for the benefit of patient without consent, that is in emergencies. So again, not punishable. So we'll come to consent, a little bit of feasibility issues with regard to anesthesia and consent. Things are slightly different for elective and emergency surgeries, as we shall see. In elective cases, you've got time, to assess with the patient's relatives and really try to understand what the patient actually wants. You can have a measure of patient expectations also. So if you are in a center which does a particular type of cases most frequently, you could have case specific information pre-prepared also. Or type specific means you could have consent forms or discussions based on the type of anesthesia which you're going to give to the patient. And it is always better that in elective cases, it's a personalized one-to-one communication between the actual doctor who is going to do the procedure and the patient, rather than delegating it to a junior or a resident or somebody else. So in elective case, you can't have the luxury of saying that you didn't have the time to talk to the patient. So it is ideal that you have separate acceptance forms for disclosure, comprehension, and consent, which means you're giving him a set of information which could be long with regard to the type of surgery, complications, alternate options, and all. And let the patient and their relatives over the patient has trust. Let them read through it, confide, discuss about this, and then come back and then proceed to giving consent after having accepted the terms which have been said in the disclosure. So the key word here is the foreseeability of injury. Foreseeability of injury means that in any anesthetic procedure, we know it could be complicated. Things can go wrong. So you may not have to explain the remotest of possibilities, complications to a patient, and thus scare him off from a benefit of a surgery from which a patient would really have benefited. Nor would you be so confident of your skills that nothing is going to happen to the patient, and then faced with a situation where the patient actually succumbs to a complication which was reasonably foreseeable. So what is expected out of a competent professional is that he is presumed to be free both from over apprehension and overconfidence, and instill the same in his patient also. Medicine, as we know, and anesthesiology, as we know, is risky. Each and every other procedure has got the potential to go wrong. And unlike the surgeons who may have a gross abnormality to be tackled at surgery, like a bleeding vessel or a ruptured an incised urethra or bowel injury, anesthesiologists deal with functional changes, deal with electrolyte changes, and other physiological derangements. So this is quite risky. So we should be able to tell the patient about the reasonably foreseeable complications. That is what is meant by this slide. So in emergency cases, there may not be time for us to have a detailed discussion with the patient for many reasons. One of them being the patient himself being unconscious, or in a hospital setup, when a person may be rushed to a hospital from a casualty scene in an accident scene where his relatives or people who are competent to have given consent on behalf of the patient is not there. So other than those situations, if the situation is such that you have to proceed with the surgery quite quick and you don't have much time for a communication, so it's better to have pre-prepared case-specific information, pre-prepared type-specific information with regard to the type of surgery or with the type of anesthesia which you're going to give. Hospitals should have that ready, and then get the consent type. But or you should have prepared disclosure sheets. Video and other media recordings is ideal in such cases because usually things go wrong with with emergencies where we may be doing surgery and we may be doing anesthesia under less than ideal situation. So it's always better to have a video recording of the consent taking procedure. And if it is such that it is not feasible, it's a very busy institute. The surgeon may be still be in theater, and when the anesthesiologist may just have finished giving anesthesia to a person before he has to start with another person in an emergency theater. We could think about having process experts instead of subject experts, people working in the casualty in the operation theater who would have had good communication skills and past experience of having to deal with such situations, who would be able to convince the patients in the absence of an anesthesiologist. So these people need not be anesthesiologists. These people could be counselors or people who are qualified enough to have the ability to transmit this vital information to the patient and other stakeholders. In case the anesthesiologist does not find time because of the emergent nature of this work. So the take-home message after this whole talk is that a consent is not just a legal, nicety. It is mandatory to have consent, and a properly taken, a carefully taken, competently performed and documented consent may still be a doctor's most efficient and valid defense in a court of law against a complication to which the patient had already which has already been explained to him as a reasonably foreseeable one. So I guess that's where I will stop our talk, and we'll meet again in our, what do you say, question and answer session. Thank you.